welcome to our So good morning, everyone. Thank you for coming out to our third CHEAR seminar for the academic year. My name is Melinda Rushing, and I'm one of the Health Services Research Fellows. And Kara and myself are co-coordinating these seminars. And so we're excited that you all joined us today. Today, we are going to be hearing from several of our faculty on just updates on some of their COVID-related research that they're doing. So I think we can go ahead and get started. Each presenter is going to introduce themselves before they begin their presentation. Because we have limited time, we are going to, I'll have to unfortunately step in if you go beyond the 7 minutes, but I think we should be okay. Kara is going to be monitoring the chat, and we'll have us time for questions and answers after everyone goes through their presentations. So we can go ahead and get started. And our first presenter is Dr. Lisa Prosser.
Morning, everyone. I'm not sure I knew I was first, but that's fine. So we've got 7 minutes. Is that right? Great. I'm going to share my screen. Is everyone able to see that?
Yes.
Yep, looks good.
It's perfect timing because I've just uploaded yesterday my abstract for the Society for Medical Decision Making meeting, which is next week. So I'm not going to go through the full abstract, which runs about 10 minutes, but I will just give you a preview and look forward to comments and questions. So in this study, we created a static decision analytics simulation model to evaluate the cost effectiveness of vaccination against COVID-19 in pediatric and adult populations. And I do just want to highlight that this was it's been a really fun project. It started really as a way to stay connected with all of our trainees in our doctoral program at the School of Public Health and with our fellows and others here at the center. So this shows our whole study team, and everyone was really engaged, all at different stages throughout the course of the project. Sorry. So we have no conflicts to disclose, and some of the funding just through our center and through the Evaluation of Child Health Initiative. I want to give a little bit of background. So while COVID-19 vaccines are currently being provided free of cost, they're subsidized, as we know, both by the government, and the administrative fee is subsidized by private health plans. That vaccination still incurs additional costs to the recipient in terms of time for getting vaccinated and potential health losses in terms of adverse events, which could cause both healthcare utilization as well as loss in quality of life, as well as loss in productivity. So measuring the economic value of government investment in this vaccination program will inform decision-making, not just for this, but potentially for future pandemics. And our specific objective was to measure the cost effectiveness of vaccination against COVID-19 compared to usual care of no vaccination with and without varying levels of risk mitigation strategies. And our key policy questions included asking how the cost effectiveness varies for different age and risk subgroups, how it varies for child compared with adult target populations, and how do incentive programs impact cost effectiveness. So given our limited time, I'm not going to go through the guts and the details of the model, just to say that we're modeling the composite vaccination strategy, so not looking individually, although we can do that in the model at each of the 3 vaccine products, but we modeled a vaccination strategy that reflects the mix of current vaccine products that are being used across the country right now. We looked at stratifying the analysis across 9 different age groups and 2 different risk subgroups at non-high risk and high risk for complications from COVID-19 illness. I'm not going to go into this. This is a very simplified schematic of our simulation model in which each individual can experience COVID-19 illness or not. They can have symptomatic or asymptomatic infection. If it's symptomatic, they can face a risk of hospitalization, ICU admission, and potentially death from COVID. Along the way, they accumulate both costs associated with healthcare utilization as well as quality adjusted life years to measure the loss in health associated with COVID-19 illness. So just to pause for a moment to kind of comment. So again, to highlight that this is not a dynamic transmission model. So it's a different type of model than the models that are being used to project the spread of cases across the country, both with and without vaccination, that we've become very familiar with over the last 20 months. But the reason for using a static modeling approach that does not consider transmission effects is in large part due to the pediatric focus of this analysis, that parents are likely to focus on direct benefits to the child when deciding whether or not to vaccinate. We know this from previous vaccination programs, and given also that the timing for pediatric vaccines has substantially lagged behind approval for adult vaccines, that even though we may very much wish that the coverage rate was much higher for adults, that even with a 70% or so coverage rate, that this reduces the incremental benefit of vaccinating children at this stage of the pandemic. And so while both the individual and societal perspectives are both important, and we'll be pairing our analysis with a dynamic transmission model in the second phase of the analysis, the individual perspective, just looking at the benefits to the vaccine recipient themselves, is a relevant lens for an economic evaluation. So I'm not going to go into any of the guts of the model, but there are each of those arrows in that schematic that we look at is parameterized with probabilities that we've developed from published data, gray literature, expert panel, when we didn't have any additional data that was available. So I'm going to skip through these slides and just jump right to the results. So this slide shows our preliminary results using a healthcare sector lens. Again, this is restricted only to costs that are incurred in the healthcare sector. And so this slide shows that incremental cost effectiveness ratios are well under $60,000 per quality adjusted life year gained, and cost saving for all adults 50 years and older, which would be considered to be cost effective by most thresholds. If we use a slightly broader perspective, so incorporating both time cost of vaccination as well as time cost and productivity loss associated with caregiving, isolation and quarantine, the results are slightly more favorable, but pretty similar and look, cost effective across younger age groups and cost saving for older age groups. For the incentive program, so here we modeled incorporating either a $10 gift card or a $50 gift card. We're just showing two selected subgroups here, but we looked at it for all subgroups. And here again, the results look favorable compared to regularly accepted thresholds of cost effectiveness, even for a $50 gift card. We look at the lotteries and bonus payments. The lotteries, there were college scholarships that many states rolled out, as well as up to $5 million in lotteries in different states, and incorporating these payments again yielded favorable cost effectiveness ratios. When we look at teacher bonus payments, there were some counties and school systems that provided up to a $500 bonus for vaccination to promote teachers getting vaccinated. And here, for young, healthy teachers, it looks like without considering additional effects of transmission or benefits to others, that looking just at the benefits to the individual themselves, that this is beyond a threshold that may be considered cost effective, but certainly for older teachers in this cohort. So I'm just going to skip to the end. So our preliminary findings demonstrate favorable economic value for vaccination against COVID-19 illness, again, under very conservative assumptions. We have not included any transmission effects, which would only make these numbers look more favorable for both child and adult populations, and for a varied set of incentive programs. In our next phase of the analysis, we'll be conducting additional analyses, including probabilistic analysis, to really be able to characterize the uncertainty around these values. We'll be combining with a dynamic model of COVID-19 infection, partnering with collaborators School of Public Health will be evaluating strategies to increase vaccination coverage, such as home-based vaccination, and also looking at the cost effectiveness of booster shots, where the additional incremental benefit is likely to be far lower than that for the initial vaccination itself. And so the economics there will be quite important. So I will stop there, and thank you very much for the opportunity to share those results. And I will turn it back to you, Melinda.
Thank you, Lisa. So our next presenter is Dr. Kevin Domkowski.
Do I have rights to share my screen here, hopefully?
Yes, you should, Kevin.
Yeah.
Great. All right. Hopefully you can see that. So good morning. And I just want to share with you a little bit of work from our support to the Michigan Department of Health and Human Services, in particular, the Michigan Care Improvement Registry, MICR team. As you probably know, we've supported those folks for lots of years. This particular work focuses on a COVID-19 vaccination dashboard effort, referred to as My Lighthouse. Just to make a distinction, this dashboard is quite different, as you'll see momentarily, from the public-facing dashboards that perhaps many of you have seen over the past year or so, which look at COVID cases and COVID vaccinations. Again, those are public-facing. This My Lighthouse dashboard is specifically focused at local health departments across Michigan. We have 45 county or county-based health districts in the state of Michigan. This is for their exclusive use. Our responsibilities were threefold. We were acquiring and processing statewide daily COVID vaccination data, which I'll show you details in a moment. We performed data quality assessments in conjunction with the state epidemiologists and MICR team to ensure data quality and consistency, particularly with other MDHHS dashboards. As you can appreciate, you wouldn't want to have two different dashboards giving vastly different information. So we were continually trying to ensure that consistency. So just to give you a quick sense of what we've been up to then, our data acquisition is as follows, from left to right, starting with the querying. Either Hannah Peng or Pooja Patel each day will run a SAS query, which goes into the back end, as we would say, of the MICR database, and queries every single COVID vaccination dose that's in the MICR database.
I'm sorry, Kevin, to interrupt, but we're not able to see your slides, or they're not progressing on our part.
Oh, really? Well, can you help me out there? Let's see.
There it goes. Okay, we're good now.
All right. Sorry about that, folks. We each and every day do the query into the full MICR database, obtaining all of the COVID vaccination doses for the state. And as I said, this is done, well, actually 6 days a week. When we do that, we get a number of doses that need to be weeded out, primarily duplicate doses. So anything that's on the same day for the same person with the same dose, that sort of thing, those are weeded out and prepared. Important part of the preparation includes geocoding. So that's latitude and longitude that's assigned to each street address in the MICR database. That process is performed by another group at MDHHS. We're able to take those data and merge it with each daily query and put it into one large data set. From there, then our CHEAR data acquisition piece is handed off to the U of M School of Public Health team that actually developed the Lighthouse dashboard. That team processes those data, does a variety of graphics and mapping related activities, and so that then that is refreshed each and every day and pushed out to the local public health departments, health departments can use those data, and they're, like I said, refreshed every single day. So a quick look at what that dashboard brings to them. Very high level start, but you can imagine that, for a county health department, let's say we're in Washtenaw County Health Department, we're going to be very focused on what's going on in Washtenaw County. We can continually drill down. This is now looking at the census tract in Washtenaw County. For the purposes of this morning, I really can't drill down any further because we'll very quickly get into the identifiable data that is underneath this. And so that is a key distinction between this dashboard and the others that are available for the public facing. This one has fully identifiable data, street addresses, names, everything, so that health departments can conduct outreach by isolating and identifying pockets of need, if, as you might say, which might be even at the, not only the census level, could even be at a multifamily dwelling in an apartment or whatever. So this drills down very, very detailed, and as I said, into identifiable data. So I won't be able to share that with you, but I will say this, is that this is the first time the MICR registry has been used for real-time surveillance of this sort. So we have this very, very granular data where we are each and every day updating and pushing it out to local health departments who are using this information. And as you might expect, lots of issues, data quality issues have arisen. And it's safe to say that any sort of effective COVID vaccination surveillance program is going to require timely, complete, and accurate vaccination data. And as I say, these the real-time use of these data has brought to light a lot of data quality issues, which that's the other part of our team's work, is working with the state analysts to identify and resolve these issues. Some of the issues include things like geocoding issues, people being put in the wrong census tracts, zip codes, counties, all sorts of issues like that. Those have been resolved. Provider information being missing or incorrect. Things like my dose shows that, oh, it was administered on Industrial Highway. Well, Industrial Street in Ann Arbor is where the Visiting Nurses Association's office is. So those kinds of mismatches, it's like, no, I got mine at the University of Michigan. We went through many, many iterations with the state team to help them sort of sort out, identify, and resolve those issues. And then lastly, there's quite a number of issues having to do with administrative dates, administration dates being incorrect. I could present actually a whole seminar on that. I'll just say that one example would be the University of Michigan hosted at athletic facilities a large mass vaccinations series of vaccination clinics that were actually administered by Kroger Pharmacy, and the Kroger team brought their laptops with them, did the administration, recorded the doses, and it turns out that when they uploaded all those doses, many of them were assigned the wrong dates of administration. So we spent the summer working with Kroger to basically get their data corrected so that the MICR registry would be complete and accurate. So I'm going to stop there because we could get into a lot more detail, but that's one example of how we're using the MICR registry during the COVID pandemic.
Thank you so much, Kevin. This is some exciting stuff that's going on. So our next presenter is going to be Sarah Reeves.
Morning, everybody. All right, can you see the correct view of my slides?
Yeah, it's in presenter.
Now we can.
Yeah.
Okay, you can see the good ones? Okay. All right, so a little bit of background. Sickle cell disease is considered an underlying health condition by the CDC that increases the risk of COVID-related morbidity and mortality. That's a bit of an assumption, as most COVID-related things are. At this point, there's no real data to back that up, but I mean, it makes a lot of sense. And then sickle cell trait, which is the carrier condition of sickle cell disease, has always really been considered a benign disease with a very few exceptions. But there's been some hypotheses that sickle cell trait could be associated also with excess COVID morbidity and mortality based on the pathophysiology of both. But complicating any study for that is that people don't know that they have sickle cell trait. Only about 20% of carriers are aware of their status. There's been a few studies that have tried to get at, these associations, but they're all really, really biased, like only among hospitalized population. And again, people don't really know they have sickle cell trait. So our objective for our study was to compare the rates of COVID infection, hospitalization, and mortality among those with sickle cell disease compared to normal hemoglobin, and sickle cell trait compared to normal hemoglobin. For our methods, we worked with the Michigan Department of Health and Human Services. You're probably noticing a theme across Kevin and I for that. And we obtained all of the COVID positive cases from March 10th through, I believe, end of July, and then the associated hospitalization and mortality data for each of those cases. We then took all of those cases and linked them to newborn screening results from births from 1987 to 2019. So note that that means we have a younger population. This is the only, we're actually one of the earliest states that have sickle cell trait results going back that far, but it's really the only accurate way to identify people living with sickle cell trait. So we excluded anyone that couldn't be linked to newborn screening or had an abnormal hemoglobinopathy result. So then all of the remaining COVID cases were classified as normal hemoglobin, sickle cell trait, or sickle cell disease. These are our, I literally mean hot off the press. I believe we just did these a day or so ago. Across the time period, remember, these are just births that could be, these are just births from 1987 to 2019. There were just under 4 million normal hemoglobin births, 2,000 sickle cell disease births, and 62,000 sickle cell trait births. You can see that, let's focus on this column first. There were 6% of the normal hemoglobin births had a case. I know this seems a little low, but remember, this is a younger population. Everybody's like under 35, right? A little younger than that even. So this isn't kind of the under 35 population. 0.7% of the cases were hospitalized, and 0.04% of the cases resulted in death. Sickle cell disease looks very different. Not really in terms of cases, and I don't want to make much assumption on the incidence of COVID. I believe that it's too kind of mixed up with testing behaviors and different things. So we can't really, I don't think we can think much about this top line. But then 1 in 5 COVID cases were hospitalized among those with sickle cell disease. This was a little bit higher than I thought it was going to be. And then 1 to 2% of cases, we have to collapse anything less than 5. So I did these percentages. If it was 1 or 4, resulted in death. Sickle cell trait, you can see a higher hospitalization rate, pretty substantially compared to those that have normal hemoglobin, and also potentially a higher rate of deaths also. So again, this is a younger population, which is why some of these numbers don't look necessarily like what you might be seeing in the news. Our next steps, and again, none of these, this is not controlling for race or anything like that at this point. But our next steps are to model the incidence rates while adjusting for potential confounders. And also the state of Georgia did the same methodology as us with relatively comparable results. Their births are a lot younger though, so their rates are somewhat lower. The CDC just gave us additional funding also to link all COVID-19 data to all individuals with sickle cell disease across the lifespan. So that will provide a lot of additional information, but we won't be able to do that with trait because newborn screening does not go further back than 1987. And then we have an upcoming project looking at COVID-19 vaccination rates among those living with sickle cell disease. And then it dovetails nicely with Kevin's because we really want to think about opportunities for improvement at the geography level. And then we have a team that works on our surveillance project, but Krista here really did all the analysis for this so far. And then Isabel Herden is the newborn screening epidemiologist, and Shannon Johnson provided us the COVID results. And then funding for this was from the CDC. So I will stop there.
Thank you, Sarah. Okay, so our next presenter is going to be Dr. Joyce Lee.
Can you guys see my screen?
We see it, but it's not in
Okay.
presenter mode yet.
And then if I advance, you can see it?
No, it's not in presenter.
Same thing. Okay, hold on. 1 second. You think we get this right after all these months? Share screen. Okay, can you see it advanced now?
Yes, it's in
Okay.
presenter mode. Mhm.
All right, so this is a study that we did with the T1D Exchange, which is a national collaborative focused on type 1 diabetes, where we all contributed data as part of our quality improvement collaborative. So this was published in DT&T in, I think, February. So, I think everyone acknowledges that we all shifted to telemedicine during COVID-19. So what we did was we did a survey of clinics inside the collaborative that spans, like, basically it's a national collaborative that spans like across the US. Most of the centers were peds, some were adults, but we just asked them about their transition to telemedicine. And then there were additional sites that were able to provide some metrics on like phone visits, in-person visits, and telemedicine visits. So the survey was fielded in June of 2020. The data was collected in July, and we captured through the end of August. So we captured from like December through August, and then I won't worry about that. So just to give you a background, so we do have a key driver diagram where we all had this imperative. I think everyone in the clinical delivery system had an imperative to increase the rate of telemedicine visits because we weren't having patients come to clinic. So this was our key driver diagram, which provided some key drivers as to what would make us successful with increasing our rates of successful telemedicine. And there were a variety of different tools that centers came up with and CHEAR and SOL in order to achieve this. In terms of our study definitions, so we call the telemedicine visit a virtual visit, which would be either a video visit, like through a Zoom, or a telephone visit. A video visit occurred by video conferencing software, so people would be able to see each other face to face, provider to patient. And then a telephone visit was a billable telephone visit that occurred in lieu of a face-to-face visit because of COVID-19. So I think many of you are aware that with families who had difficulty onboarding to the portal to do the video visits that way, sometimes we just had to do simple telephone calls. So our outcome measures included the monthly metrics and then survey responses from the sites. So these were our 12 clinical partners who were able to provide some quantitative data. So at the top, what you have is just the number of visits completed by all of the centers across the board, regardless of in-person, telephone, or video. What you can see is the number of visits by month, and then you can see the proportion of visits by month. So the dark blue represents in-person, right, which went to almost nil in April 2020. And then we have telephone visits in sort of the bright blue, and then we have video visits in the yellow. This is a look at how the adoption was across the study period, across different centers. So what's sort of interesting is that a lot of centers, see the blue area, relied on phone visits as sort of their main port of entry to ramp up their telemedicine, and then were able to make a shift over to actual video visits, right? Because there's this notion that once the pandemic is over, CMS and other insurers will not pay for phone visits in the same way that they would pay for telemedicine or video visits. What I also think is really interesting about this is that we have a number of, these are all different sites, but there were a number of, they're basically in some of these groups, there's like 2 to 3 centers that reside within a particular state. So you would expect that there would be state level policy implications for adoption or persistence of adoption. And what we essentially found is that there was varying levels of adoption by August 2020 that was sort of independent of the state that individuals lived in, or sorry, the centers that the individuals resided in. So there's certainly like other factors beyond state level policy that probably impact adoption and persistence of telemedicine. I'll get rid of that. And then this was in dark blue, what you have is the percentage of visits that actually had a hemoglobin A1C. And then you can see that in April and May, we sort of just all as a group stopped doing labs because we usually get a hemoglobin A1C as part of our evaluation for chronic disease management. But eventually we were able to find ways to kind of bring that rate down. So we have been engaged in a number of, I guess, more qualitative center level discussions about the pain points around telemedicine. And I will say the two biggest ones that centers have indicated are that one, the pre-visit prep for telemedicine is extremely arduous, and getting data downloads from families is also a big struggle because we have a lot of platforms that people upload their CGM, their pump, their meters to, but it's actually quite difficult to have the patients do it. They normally would just do it when they came in for clinic. So there's a lot to be realized as it relates to like, I guess, the promise of digital health, because most of us are still struggling with trying to get a PDF sent to us through a portal message so that we can see it in the media tab so that we have data at the time of the video visit. So, and then I'm not going to go through all of this, but just to give you an example, most centers, so this is a center level survey, most centers are using Zoom. We're using Zoom at the time. We actually are going to be repeating this this year to see what the update is the one year later. Again, there are a lot of different platforms that we have to use because the different devices have proprietary platforms that allow us to access data for specific patients. But I will say that, you know, the number of centers that have data integrated into the EHR is very small. It was just 1 out of 24. So I won't go any further. Happy to answer any questions.
Okay, thank you, Joyce. And we do see that there's a couple questions that were posed in the chat. And once we get to the Q&A time, we'll go ahead and address those and then open up the floor. But before then, our last presenter is Dr. Fola Odetola.
Morning. Can you hear me?
Yes.
Oh, perfect. Okay. Hey, can you see the slides right now?
We see them, but they're not in presenter mode.
Yeah, it's just 1 second. What happened to this? Is it clear now? Is it visible? Oh, not
No.
yet. Okay. I wonder.
You have to share the screen.
Yeah, okay. Not yet. Yeah, for some reason, it's weird. It just keeps taking out the option to swap.
It's not in presenter mode.
Yeah, that's the problem.
The little button on the bottom right, you might be able to use.
Just
There.
okay. what can you see now?
Perfect.
Yeah.
Yeah, for some reason, it just kept minimizing. Okay, I'll speed through this. So I'm auditor. I'm one of the critical care pediatricians and chair faculty. This is a tale of 7 cities, a perspective, or the perspectives from pediatric critical care medicine physicians who provided care to adults with COVID-19 during this pandemic. And as we know, this is an ongoing worldwide epidemic, and to provide care to the massive number of individuals that were hospitalized, especially during that first wave of the pandemic in different regions of the US, hospitals and health systems essentially surged in their resource capacity in various ways, including the redeployment of human and material resources to provide care to as many people as possible. And resources often devoted to children were actually redeployed to take care of these adults who at that time were disparately more affected by the disease. So attending faculty within PEDS critical care were redeployed to adult ICUs, and some pediatric ICUs in the country were actually repurposed to adult ICUs, staffed, by the way, by pediatric ICU faculty. And this was a very rapid redeployment activity actually across the country with very little time to prepare. So we wanted to determine the physician level and perceived institutional drivers of this redeployment of physicians, the challenges these individuals faced and the lessons they learned while they provided care to these adults. With the hypothesis being that the deployment or redeployment of these physicians during this ongoing pandemic, particularly during that first wave, was driven really by a sense of altruism to provide essential care to these adults and prevent burnout amongst our adult critical care colleagues. So our goal was essentially we were able to talk across the country and figure out that there were at least 7 pediatric ICUs that were undergoing this alteration in care delivery model. Michigan, New York, Massachusetts, Maryland, Arizona, and Utah. And we wanted to represent all the 4 census regions of the United States, oversampling New York being the epicenter of the first wave of this pandemic. And those are our subjects right there. And this was a mixed method study, both quantitative and qualitative, with data collection on the qualitative side, focusing on video interviews of at least 5 pediatric ICU attendants per site. And each of them received a $100 gift card as a token of appreciation for their participation in the study. Each site PI filled out a questionnaire on the quantitative side to ascertain the key structural ICU variables, including patient census during this period, both adult and pediatric patients, availability of specialized technology, the number of pediatric ICU attendants and nurses redeployed, and actually were able to get into trainees also amongst multiple resource variables. The interview script focused on 9 different domains, all the way from training and normal scope of practice through the challenges these individuals face, the toll the pandemic took on them, or is actually taking on them even now, and what they felt the future held for the country in terms of preparing for future public health emergencies. We've concluded the interviews. Now, we were very grateful that we actually exceeded our goal. We actually have a tale of 8 cities now in 9 hospitals, or you could flip that around, tale of 9 hospitals in 8 cities across the US, 40 participants rather than our target of 35. And these are the sites that participated. And as I mentioned earlier, New York was oversampled. So we exceeded our goal. We've completed data collection, transcription of the data. The initial data verification is now been done. And now we're essentially conducting secondary data verification and coding of the data simultaneously. And what do we think we're aiming to sort of figure out here? Well, we feel that greater understanding of the magnitude of resource distribution or redistribution that accompanied the redeployment of pediatric ICU attendants and other pediatric focused staff will be very important moving forward and planning for future public health emergencies. And if we can understand the challenges they faced and the lessons they learned during this process, we can essentially do a better job next time, because there will be a next time. And these experiential findings might provide needed information to inform decision makers involved in pandemic preparedness. So I and Erin Carlton are the principal investigators on this study. Rennie Anspach is from the College of LS&A, and Alisa Dews is also on our research team. And the study was funded by the CHEAR intramural funds. Thank you.
Thank you. Thank you to all of our presenters. So now we're going to go into our Q&A time. And so I'm going to start off with the first question that was posed in the chat was actually for Kevin. And the question is, do you have any ideas or recommendations for how to improve quality of data entry without compromising completeness?
Yeah, it's a great question, Toby. So the short answer would be, if we consider electronic health records, EHRs, as sort of the gold standard for not only clinical information, but even what we know about patients, things like their contact address, their residence address and so forth, we can go a long way toward not only improving the completeness of things like COVID vaccination doses administered, but actually where people live. So if you caught what I was saying, we had a lot of issues with things like, incomplete information about providers administering the doses, as well as where persons lived. Some of that has to do with bad address data. And if we could get more of our data electronically uploaded directly from electronic health records, which is this interoperability that some of you have heard me talk about before, that will in fact improve the data. One thing I will say is, again, this is the first time we've used a MICR registry in real time to do this sort of like very granular sort of surveillance. And we're focusing primarily on adults. And the MICR registry, although it is authorized to include adult information, it's not required by law. So there's a lot of incompleteness still in the adult part of MICR. So there's some room for improvement there. But I think that the short answer is electronic interoperability will go a long way toward some improvements.
Okay, thank you, Kevin. And so then our second question in the chat was actually posed to Sarah. So the question's from Jeremy, and it asks, were you able to control for race? We've seen data about increased hospitalizations and mortality for African Americans. Is the trait finding above that expected by race alone?
It's a great question, Jeremy. So we did a really quick calculation where we just actually, and this is not the methodology we're going to really use, but we just limited it to the population that was identified as Black in newborn screening. And actually, that's probably the best secondary source of race and ethnicity data that we have, because it's directly populated from the electronic birth certificates. And when we did that, everything was cut in about half to a certain extent. So the hospitalization was 20% higher for trait and 30% higher for death. And for sickle cell disease, hospitalization was 10 times higher and about 20 times higher for disease, for death. And so another thing that we're going to actually use this data for, is, since it actually is pretty good representation of race, is I think we're going to be able to look, we're going to actually do COVID hospitalization overall by race and ethnicity using the newborn screening data also.
That's great. Thank you.
Okay, now we can open the floor if anyone just wanted to take themselves off mute and ask a question to any of the presenters.
I have a quick question for Sarah, just a quick follow-up on that. Can you say just anything a little bit more about what Georgia found? I know you said that they are doing or did do it in parallel, but I didn't see the detail yet on the Georgia findings. Is there anything you can share?
So their hospitalization rates for disease were much higher than normal hemoglobin. And for trait, there was an increased risk also of hospitalization, but they actually had no deaths across the sickle cell trait or disease population, because it's only births 2008 and forward. So it was really young, but obviously we're all very glad to see no deaths in that age group, in those groups.
Great, thank you.
Toby had a great question that she just put in the chat, so I'm going to read it. This is for all the presenters. You know, the last presenter shared about funding sources and curiosity about how the other projects presented were funded. Were they pivot projects or were kind of other sources identified?
Mine was a specific COVID supplement from the CDC that built upon CDC funding for our sickle cell surveillance system.
So ours, the MICR work was, we have ongoing funding for MICR data quality, but pre-pandemic, nothing like this, of course, was imagined. We would have sort of an ongoing set of funding for issues as they arise. And that was, in fact, obligated, and I guess to use your term, Toby, it was a definite pivot there. The state decided to use those resources entirely for COVID-related activities.
We were doing it for quality anyway, so I mean, everyone had to scramble a bit and sort of pivot to this topic, but I guess that's one of the advantages of working with larger groups that are already aggregating data and trying to do improvement. So.
And ours was primarily a volunteer collaborative effort, although we did secure some funding from the medical school kind of midway through the project. And the CHEAR Center, I like to acknowledge the CHEAR Center because our center provides important infrastructure support. Some of my students utilize space here, but the CHEAR Center did not provide specific allocated funds for this study, but it was primarily a volunteer effort.
Okay. I actually, if anybody else, sorry, before I ask my question, I don't want to take over the mic. If anyone else wanted to come off mute and ask a question or put it in the chat. Okay. I actually had a question for you, Joyce, because I know that with telemedicine, a lot of institutions are looking and measuring like the increased use of it during this time. And I noticed that in your figures, it kind of clearly showed that early on when like everything shut down, telemedicine shot up. And then by August or so, when things started to open back up, then it went down and the in-person visits started to increase. And I know there's also a reimbursement challenge that's there to keep telemedicine going. So I was wondering if you had, or what your thoughts are, just, I guess, benefits of maintaining like access or increased access to telemedicine after, or when things maybe get to a more settled place and we're able to move around and be in public spaces easier.
Yeah, so I mean, I feel like there's just a lot of center level factors that may lead to sort of center and probably provider level factors and patient level factors, right? Because I would say that like some families who are driving like 3 hours to come see us, like they think it's a total win because it takes them half an hour from their home and they don't have to like spend the day off of work and school to do it. I mean, just anecdotally, I will say that there are families who are like, no, I want to see you in person because they just feel like it's a more meaningful interaction, even if a lot of the transaction that happened, which is like data review, changes in doses and addressing concerns, right? Like it, yeah. So but I will say that I guess structurally, the problem with telemedicine is that we have Zoom, but there's actually no structure that really probably adequately supports it for the providers, right? So you have to get labs ahead of time and get those ordered. You have to warn people because they forget, right? You have to get them to do their download 24 to 48 hours ahead of time. And I think, essentially what has happened is, here in our pediatric diabetes clinic, we've had some people pivot towards like supporting that, like calling people ahead of time and sort of trying to get that work done ahead of time. But I wouldn't say structurally that it's actually, there's not like a good infrastructure like there is right now for just bringing people into clinic. So I think that's probably why the rates have gone down quite significantly, because people just find it to be a bit of a hassle because they might have a missing download or they may have patients no show. And So I think great opportunity. I have seen some patients that I otherwise probably would have never seen because it was easier for them to get there. But I think structurally we haven't necessarily made a transition as health systems to adequately support it. Right now, we are still getting COVID-19 kind of like pandemic coverage, but that probably will change right after the pandemic is over. So.
Okay, well, thank you all again for just coming to this seminar and hearing about this amazing work that's coming out of the center right now. Thank you, presenters, for sharing all the great things that you guys are doing. It was very insightful. And if we don't have anything else, so we hope that everybody has a great day.